Vanakkam. My apologies. My apologies for coming so late. And secondly, for not being able to speak in Tamil. Thanks to Tamil movies, I am able to understand Tamil. But speaking is beyond me. You will not excuse me if I try to speak in Tamil. I am so very glad to be here on this happy occasion. When the seeds, just as a sapling is planted there, the seeds of a very compassionate action are being planted here. And when the society as a whole, all over the world, is going from the extended family structure to the nuclear family, from humanity to commerce, from service to profit-oriented motives, healthcare system, which in the last half century got converted from health service to healthcare industry, these efforts are of great value. Mr. Shankar Mahadevan and team, it's certainly a proud privilege for me to be here on this day. I am so happy that others coming from other towns are here. I see Mr. Sendil Kumar here, who has done such a great service in the town of Nagarkoil. I am glad that my wife, Dr. Chandrika, who is also a pathologist, is able to accompany me and to see the work that you are doing with cancer detection. Respected senior members of the profession, I find here somebody who was even senior to me in my own medical school by about 10 years. And dear friends, I think everybody here would have some idea of palliative care. And whether you are a medical person or not, you are likely to have some lack of clarity about what palliative care is. The lack of clarity is inevitable because even the World Health Organization changed its definition of palliative care 12 years back because what it came out with first is found to be inappropriate as palliative care expanded and solidified in the last few years. It is still undergoing some changes, it's being molded. But as it is, what it means is something that I'll tell you, and generally I'll try to put it into the context of our country. This month, on the 1st of June, in Kerala we claim that we are the most progressive state in India. We are not afraid to boast. There's a lot of boasting going on with us. And on the 1st of June, in the North Kerala town of Kanyanad, a father killed his son. A father put a noose around the neck of his 11-year-old child and killed him. Then he and his wife themselves hung themselves and committed suicide. He is not a cruel masochist. He was a loving father. What does it take for a loving father to put a noose around the neck of his own precious child and to even not to loosen the grip even when the child struggles? What pains must have gone through that family? And this happens in our progressive state of Kerala. The father had left a suicide note saying, "We are doing this because we are unable to see my child's pain." If you think this is an isolated event, I am sorry, it is not. In our work, time and again, we see people coming with a scar around the neck. We had a young man recently. He had such severe pain and no doctor would give him enough pain relief, and he hanged himself, and as he did so, the chair that he was standing on, which he kicked out, fell and created a noise. His two children, 12 and 7 years each, came running, lifted the father up and saved the father. He eventually died of kidney failure after a few weeks. But those two children would even now be living with such a huge scar in there. Will their brain be any time as normal as somebody else's when at that tender age they had to go through that experience? All these patients in pain, okay, not all, let us say 2/3 of all people in pain need morphine or a medicine of that class. Of that class, even today, morphine is the only thing that is available in our country for oral use. Nothing else is as tablets or liquid. The government of India has made it an essential medicine. In the injectable form, it is necessary if you end up with a heart attack. It is life-saving. It is life-saving. It is that important. Both the injection and tablet are in our essential medicine list. But that hospital in Kerala, can you go back to the last slide and just leave it there? Thank you. That hospital in Kerala which treated this family in that hut did not have this essential medicine. I strongly suspect that not even one hospital in the city of Tirunelveli has oral morphine. I may be mistaken, but I suspect that I am not mistaken. Shouldn't somebody stand up and ask the question, why does your hospital not have this essential medicine? Oh, you can give all sorts of excuses. The most reasonable excuse is that even today, you will be surprised to hear this if you are not a doctor. You will be surprised to hear that even today, assessment of pain and proper management of pain is not taught to medical students. That's a big statement to make, but and I am taking responsibility for that statement. I am making the statement that even today, all over the country, except for a handful of institutions which are doing it by themselves, proper assessment and management of pain is not included in the medical or nursing curriculum. Shouldn't somebody stand up and ask some questions? Because unless we go through that kind of experience, we don't know what pain is. I don't know what real pain is. Many of us would have gone through severe pain, the pain of an operation, the labor pains, or even some crush injury, a traffic accident. Many pains we have undergone. And we are likely to think of all pains related to our experience. But it can be, imagine what the worst pain you have experienced. Imagine something 10 times as bad or 100 times that bad. One of my patients described his pain. What he said was, I will show you his picture later. He had a cancer of the tongue and it had spread. He said, I feel as if somebody is putting in a red hot iron into my bone and that's being twisted all the time. Remember, this is not for a minute, this is not for an hour or a day or a week. Sometimes it is for months. Another person with again a head and neck tumor said, I feel as if somebody is putting a nail into my ear and driving it with a hammer. And he said, it starts, I have no control over it, I keep my hand on my ear to prevent it, but it still happens. And if it starts, it goes on for about 10 minutes. Then I lie down exhausted, and then it gradually stops, and after another 10 minutes it starts again. This kind of pain, 2/3 of all this kind of pain can be relieved only with morphine. But just giving morphine to this hospital is not enough. It will only cause problems. It requires training. Doctors and nurses need training. It is not complicated. There is no rocket science. It's very simple, and the medicine is inexpensive. Perhaps that is the problem. If something is not expensive, today's healthcare industry rejects it. Not only rejects it, buries it so that it doesn't come up. It's not nice. Cheap, inexpensive medicines are not good for the healthcare industry. They are buried. So far I have been talking about the poor people. Well, how about the rich? If you have money, as the majority of audience here in this hall have enough money to avoid to go to a good hospital. Sorry, the good hospitals also do not have medicines like morphine. They have very expensive medicines. They have very expensive chemotherapy. They can give you interferon, but not morphine for your pain. They don't have it. It is too cheap. Can I have the next one, doctor? You and your loved ones, your wife, your husband, your uncle, your aunt, your father, your mother, your child, if they have an incurable disease, is going to be in there. This is worse than the other person suffering. Because here, you are not even able to cry and get somebody to help, because there's a tube down the throat. Today, no one who has enough money is allowed to die a normal death. You die in an intensive care unit. 2/3 of patients in intensive care units today have incurable diseases. They are there to die with misery at great cost. There is a tube in every orifice. Your family is not allowed there. And that, I think, is the most cruel phase of today's medicine. Someday, I've told my wife, when I go, this is one way in which I certainly do not want to go. Before I go, if I want to say a final message to her, I want to be able to do that. If I want to hold on to my son's hand once more and tell him, I love you very much, I should be able to do that, if I have the strength. I don't want them shut outside with me, with 100 wires around me. And what's the point? What do all those tubes do? Do they prevent death? Even today, mortality of the human being is still 100%. We are all going to die. And natural death has some dignity to it. That kind of death, lonely, unable to see your loved ones, unable to see give a final goodbye kiss to your grandchild or granddaughter, that is not humane. And by the time I would go through the process, she would have no home left. An intensive care, depending on the facilities of the intensive care unit, costs anywhere from 15,000 a day to 75,000 rupees a day. The family is destroyed in the process. Why am I saying all this? There are two kinds of suffering. The suffering of the poor, the suffering of the rich. Nobody is immune. Whether you have money or not, if you have an incurable disease, you are likely to get inappropriate treatment. And this is where your initiative, Mr. Shankar Mahadevan, comes in very important, because now, at least at the end of the life, we can expect to live with some dignity and hope to die with some dignity. I will try to give an overview of palliative care. Can I have the next one? Thank you. Next one, please. Uh, there are about half the audience is comprised of healthcare professionals. Healthcare professionals, right? This is health, as defined by the WHO in 1948 and not changed. This is still valid. Health is not just absence of disease. It is also complete physical, social and mental well-being. Does healthcare attempt to do this? Unfortunately, as especially in the last half century, health became more and more disease focused. Our training for 5 years of medical education, 1 year of internship, another 3 years of postgraduate education, and maybe another 2 or 3 years of postgraduate fellowships. They are all aimed at identification of the disease and destruction of the disease when that is possible. When the disease cannot get cured, it's easy to say, I'm sorry, there is nothing more we can do, and anyway you have no money in your pocket. Take him home. If you have money left in the pocket, even that is denied to you. Next, please. That's definition of palliative care by the World Health Organization is too long. So I have pointed out some words in red. It's about quality of life. Disease is not the only thing that matters. If I have a disease here, don't look at me as if I am just this adenocarcinoma of the lung. Look at me as a human being. I am a human being with emotions, feelings, gratitude, sorrow, everything. And please take me seriously, and whatever you do, please do so that our lives have reasonable quality of life. We are not just existing as beating hearts and pumping lungs. We should be able to live, not just to exist. And we usually, the hospitals, we doctors, nurses, consider bystanders a bit of a nuisance. So we keep armed guards at the gate to stop the relatives from coming in. Of course, there is some reason for it, because sometimes somebody being in a hospital is taken as a social occasion for a visit by about dozens and dozens of relatives. But this bystander, again, is going through the most intolerable suffering of their lives. So we are talking about in palliative care, what you are going to do here is trying to look at the quality of life of the patient primarily and the family secondarily, and try to improve that quality of life. That's our job. Make life livable for them. For this, can we go back? Look at the bottom. We need to treat pain. Pain has to be taken seriously, not to be laughed at, because pain can be excruciating. We treat pain and also other physical problems. Like if somebody is breathless like that, we should be able to relieve that breathlessness. But also psychological problems, the depression, the grief, the anxiety, the fear, the guilt, everything. And also the social issues. Irritability causing disruption of relationships between family members, the poverty, the children dropping out of school because the money is not there for the school fee. All these are part of it. The stigma, the fear of cancer in the family, the daughter not being able to get married because that's a family with cancer. All these are part of the suffering. And spiritual issues. What's the meaning of life? What's the point? Why am I alive? What was the purpose of my life? And why is it ending like this? Why has God deserted me? All these spiritual issues are also causes of suffering. What we can do is to identify those elements of suffering. We cannot take them all away, but many of them are unnecessary. Once you identify them, very often we are able to find a solution for it. Can I have the next one, Doctor? I understand that in the whole of Tamil Nadu, 1.8 lakhs of people live with cancer. There must be at least 70,000 people in the whole of Tamil Nadu who have severe pain. Only a few centers, maybe 3 or 4 in Chennai, I know of one each in Trichy, Madurai and Coimbatore, doing some sort of care, maybe a few other places also. And now Chandil has started this in Nagarkoil, and a bit towards the west in Kulasekharam also a team has started something. So Kanyakumari district is perhaps doing much better than the rest of the state, but still all of us put together would not be treating even 500 of these 70,000 people in pain. There is so much to do. And remember, cancer is not the only disease that causes pain. In our unit at Trivandrum, as some of you have seen, only about 50% of the patients come with cancer. Others come with a lot of other diseases, all incurable usually, like people struck down on the road with and sustaining injuries to the spine and becoming paralyzed below the waist, people who get a stroke and one side getting paralyzed, or many other diseases, liver, heart, lungs, everything. Once it is beyond a certain level, the cardiologist has little to offer you, and that's where we need to come in, work with the cardiologist, with the hepatologist, with the kidney doctor, everybody, to improve the quality of life. Next please. The World Health Organization came out with this WHO 3-step ladder for pain management. This was in 1986. 28 years later, even today, it is hardly used in this country. Okay, Nagarkoil and Kulasekharam have it, but even there I expect, Chandil, that even in the city of Nagarkoil, only a minority of people will be able to actually access this, because hospitals do not have it. Hospitals do not refer these patients to you, and patients do not know about it. And in the step 3 of the ladder, the only medicine, as I said, that can be procured is morphine. Tamil Nadu has simplified its narcotic regulations. I think it happened in the year 2000. So you have a fairly simple way of procuring morphine. You don't need to go to excise to get the morphine license. You can just get it from the drugs controller. But you need a doctor with at least 10 days of training. And do you think that's such a huge stumbling block? Just one doctor in a hospital with only 10 days training? Yes, it is a stumbling block. That is what holds up the service, because the community wants it. Usually hospitals are not ready to send somebody just for 10 days, and usually doctors very often do not have the commitment to take those 10 days away. What happens to their practice? When they come back, have they already lost some of the patients? These are all real issues that they face. Next please. When I have said the word morphine, some of you have wondered, but how about addiction? Is that not a problem? And doctors are generally afraid of respiratory depression, and I must make it a clear statement, and if anybody needs clarification after this session, I am very happy to explain it in greater detail. Medical science has very clearly established that if used with reasonable precautions, we are not talking about high-tech precautions, reasonable clinical precautions, oral morphine is very, very, very unlikely to cause addiction or depression of respiratory breathing. I am talking about oral morphine. Injectable morphine has to be used with greater care because it can be abused much more. Next please. Just because there are a few doctors here, I will just draw one example to show how treatments that we have learned in medical college has to change in the context of an incurable disease. Look, if I am coming to you with a cancer here, advanced, all treatment is over, I am unable to breathe, like this I am coming to you, what will you do? I'll tell you what's likely to happen. You are likely to push me into the intensive care unit immediately. Look, if this cannot be cured, that intensive care is not going to be helping me. I still want her by me, to hold on to my hands, to cry with me if necessary. That is an enormous, powerful support. Please do not isolate me in that context. I know intensive care can save lives. If there is a traffic accident and injury to the ribs, if there is a heart attack, you need intensive care. But even there is really no justification for the isolation that is inflicted on people. Well, anyway, no, I am not finished. Will you give me oxygen? Yes, I am sure. I may be helped by it. But if I have an obstruction here, doctors, if my airway is obstructed here, if you give me oxygen from here, will it really reach my lungs? Maybe a tiny little bit. If not, this is going to be a nuisance for me. Question to the nurses here. When you give oxygen to patients, do many of them keep pulling the mask away? Do you see that happening? And what do? Push it back on the face. What does the person do? Pull it away again. Then either you pretend not to see and the mask is giving oxygen to the atmosphere, or you tie the person up. What is happening most likely is that oxygen is not helping that person. Just giving this oxygen is a ritual for us. It has to go through my lungs and reach my blood, and only then it will help. If there is a blockade here and it is not reaching my alveoli, or if there is a problem in my lungs and it is not getting into my blood, this ritual is meaningless. And I will only feel as if something is suffocating me. Naturally, I will try to pull it away. And if then you tie me up, it is rather cruel at that point of my life. I will give oxygen. I am not saying anything, doctors, that I do not practice. I am saying only things that I do. When such a patient comes to me, naturally even the family will be saying, doctor, give oxygen, give oxygen. I will say, I am going to put oxygen on. We are going to try for 10 minutes. If it helps to make you feel better, we will continue it. If not, we will take it away. Because I know and you know that the inspired, breathed in oxygen and the blood take only 7 minutes to reach the optimal level. If it does not help in 7 minutes, it is not going to help at all. And therefore, if that oxygen does not help, I will take it away. Once I have given the explanation in advance, the family is able to accept it, unless there is a doctor in the family. If there is a doctor in the family, they find it very difficult not to be technical about treatment. More than the oxygen, what is likely to help me at that time is maybe Mr. Shankar Mahadevan standing beside me, maybe with a hand on my arm and saying, we are going to look after you. We are going to do our best for you. Thank you very much. That's what I want. I know you are not God. Madam, there is a limitation to your powers as a doctor. I know that. But I want that assurance that you care for me and that you are going to do your best for me. That will help me to ease my breathing a little bit. But medically, giving corticosteroid medicines like dexamethasone to reduce the swelling around the cancer, or giving small doses of morphine to ease my breathing, those are things that are likely to help me. So this is not a situation where there is nothing more that can be done, but let us not do foolish, inappropriate things like sticking a tube into my trachea. If there is an obstruction here, what's a tube here going to do? And once the airway has divided into the two parts to the two lungs, you cannot put in a tube there and overcome the obstruction. It's not possible. It's not feasible. So I am not going into the more of the medical side here. I just mentioned that to highlight the point that you have studied your textbook of medicine by Price or whoever it is, or Anderson or Davidson, and there are some things that are missing there, for which, next please, that you will see that only if you go to the Oxford textbook of palliative medicine, not the Oxford textbook of medicine. And I will not go to the details of this example, how you will treat an intestinal obstruction in an advanced cancer, because this audience has more of non-doctors than doctors. I will skip that. I'm just saying, for every problem, when you think from the patient's comfort point of view rather than cure, there is a change in the way you address the problem and make the treatment appropriate. Next, please. This was the man, Shashidharan, who told me that his pain was like a red hot iron being pushed into the bone and twisted all the time. So somebody like that, he was 42. His wife has always been a housewife, because Shashidharan was a very proud man who thought the man must earn for the family. He did not allow his wife ever to go out and work. And he had 2 children, both school going, and he was having this kind of pain. He could not swallow. There is a tube down his throat. He has an ugly tumor on the other side of the face. He did not want that side to be photographed, because he did not want to see himself with that ugly thing on his face. With all that pain, he was unable to swallow. He had several problems, and now he was having some difficulty in breathing. I asked Shashi, what is it that bothers you most now? I thought he would say the pain. He said, I did not get an education. My wife never got an education. There is only one thing that I wanted in my life. That was to give my children an education. And God, now that is not going to be possible. I am saying this because we doctors and nurses look at the disease, and it's not our job to see all this. But for Shashi, this was the most precious thing. And this is where this group gets its importance. Here is a group where the doctors, nurses, etc. join hands with human beings, just people with a heart. Because Shashidharan's problems are not only medical. Okay, he has a cancer in his jaw or tongue, which has infiltrated into his jaw. But his problems are also the children's education, the social isolation, the worry about his daughter's wedding when she comes of age. All these are his problems. His anxieties, his fear, his anger, his guilt, all these are problems. His problems with his God, with whom he is now angry, is also part of his problem. And we don't need a doctor or nurse necessarily to look after 3/4 of the problem. True, without that doctor's help, without the doctor coming in and treating his pain, he cannot concentrate on anything else. 90% of his brain is filled with his pain. But once it goes off, once you take care of that pain, then Mr. Shankar and team and Shendil can come in and be that human being, assessing all the other psycho-socio-spiritual problems and doing what they can about it. This is where the symbiosis can come in. I expect that in a few months, when you get started in this beautiful, lovely place, oh, I simply loved that courtyard. I hope to put a chair there and sit there for a few hours someday. In this beautiful place, homely place, I hope you will not be stuck inside this place. I hope you will go out into the community, because the most of the people who need you will not be able to travel here. I hope, like Shandil and team, you go out into the community. Find the person where he is, because that is where he is. He cannot come. And at the last point of your life, however much facilities you give in your new palliative care center, most people would want to spend their last days at their homes, provided we can give them enough support at home. Having said that, home visits are expensive. Expensive for the provider, expensive for Udavum Ullangal. Udavum Ullangal will find it hard to find the money, because you have to find the transport, you have to find the staff. You will waste a lot of time on the roads, as we did this morning, because of our transport system and the way the roads are managed. There are no signboards, there are no street numbers. You will waste a lot of time. You will be able to get to maybe 7 or 8 homes in a day. The same team sitting in a hospital will be able to see 25 patients. But so what we do is, for anybody who is able to travel to the hospital, we tell them, please come over. If they have problems that cannot be solved at home, like breathlessness or pain that is not sufficiently relieved at home, something like that, or they get delirious towards the end of life, agitated, the patient claiming that the daughter is trying to kill him because the wiring here goes wrong. In those situations, we may have to put them in. You will need a few beds, not to keep patients forever, but to make them better before you send them back home, or sometimes even as a place for them eventually to die well. But for those who are too sick to come to the hospital or too far away, well, as far as possible, we should be able to provide home visits. The team who visited us in Trivandrum has generally seen that we have catalyzed the development of similar groups in several places. In and around our city of Trivandrum, there are now 12 small organizations, each giving care in their areas. They cannot find a doctor with training to help them, so our team goes there once a week, but for the rest of the week, they are the ones who go to the family and care for them. Next, please. When we go to their homes, one of the important things that we have to do is to teach the family how to care for the patients. You know what happens in a typical hospital environment? We do all the care. The doctors and nurses give care. The family is waiting and just running around getting medicine from the pharmacy, etc. But then you discharge them from the hospital, all of a sudden they are going to be the doctor and nurse and social worker and everything. If there is a spine injury, you fix the spine, put in a catheter into the bladder and send them home. And they have to come back every 3 weeks for a catheter change. The first day we did a clinic in Kulashekaram, Sindhal was there. We found one family there who said their relative, who with a spinal injury, had to find 7,000 rupees every 3 weeks for a catheter change. 4,000 was for a vehicle, for a taxi to be hired, because the man was too sick to sit in an auto rickshaw. And 3,000 rupees was the average hospital bill for some investigations of doubtful value and some medicines of doubtful value, and 7,000 rupees every 3 weeks for a family which has lost its breadwinner and no source of income anymore. And if we go there, we are able to teach the family. We actually teach families to do intermittent self-catheterization of the bladder. Patient does it himself or a family member does it. And they do it very well because they have so much commitment. Next. Let me bring up before you the concept of the social capital. Today, generally, the wealth of a society is considered in terms of its money. That's how World Bank classifies countries. But there is another huge wealth in the community, that's the social capital, the element of goodness in the community. Now, at the micro level, there is the patient and family. At the macro level, there is the government, healthcare system, hospital, etc. And the community comes as the meso part of the social capital, something in between. Those of you come from villages will know, if there is a one person screaming in a house, all of a sudden the neighbors will converge on the spot. It is not a matter of that family alone. Whereas in the city, in the high-rise apartment building, in one flat, there is a scream. What will happen? The neighbors will put a pillow closer to their ears and try to get some sleep. If it goes on for half an hour and they are forced to wake up, they will try to look for the number of the police, the fire force, etc. and make a call. That's all that is likely to happen. What it means is that in the world over, gradually, we are losing that middle part of the social capital. We are slowly getting more and more nuclear, with less and less of social involvement. Oh, sure, there is a residents association, everybody gets together, and there's some club where everybody gets together for a drink, but none of these is available when there is somebody screaming at night. And how does this matter for healthcare? Next, please. For that family in Kulashekaram, who needed 7,000 rupees for a catheter change, it was only the family's business to find the money or to sort the problem out. This macro part of the hospital had no relevance. What we are doing now is, next please, put the family on top and rebuild that community. At Kulashekaram, now there are so many ordinary human beings involved. They have taken some minimal training as volunteers, and then they take the responsibility to build that support system. Now that man does not have to go back to the hospital anymore for every 3 months for a catheter change, because a nurse reaches him in his home every 3 weeks for a catheter change. The total cost is less than 200 rupees, including the transportation of the nurse. So this is what is possible. Healthcare system, instead of being something that bleeds the patient and family, becomes the benefactor that it should be, for which we doctors and nurses have to undergo a change in the attitude. I myself found it very difficult, because I was so comfortable in my hospital environment. Accepting others as our equals for us doctors is not so easy in the hospital. But once we accept that there is a limit to what we can do as doctors, and that trained volunteers can do even much more than I for the patient and the family, then the service really assumes a heart and grows. Next, please. Volunteer Mr. Shankar Mahadevan and his colleagues together, they have taken the initiative for forming this palliative care service. You, I am sure, will be able to support patients in so many ways, like getting that medical support there, giving psychological, social and spiritual support. Of course, it will be necessary to improve awareness. In our own organization in Trivandrum, we found that about 50 meters away, there was a woman suffering from advanced cancer. in great agony because she did not know about us. We were so close, but nobody knew. We did not know that she was there. She did not know that there is such a facility. So improving public awareness is a great part of your work. I'm so happy to see that the press was here and media was here, and this needs to be built, and generally people have to understand that much of the disease related suffering in the community is avoidable. Next please. Just for your information, just less than 1 month back, the World Health Assembly, which is the decision making body of the World Health Organization, passed a resolution. This of course took a lot of advocacy, but now it has asked all member countries to make sure that palliative care is an integral part of healthcare as a whole. In treatment of any disease, the principles of palliative care must be incorporated. Next please. The government of India itself in 2012, less than 2 years back, a year and a half back actually, came out with a national program for palliative care. So now the government's cancer centers are asked to use 10% of the budget, their budget, on palliative care. It's nobody really scrutinizing if they are doing that, so I don't know how much it will be implemented, but this decision has been made. Next please. The Medical Council of India has already started an MD program in palliative medicine. Only one institution today has it, that's in Mumbai, but more are coming forth. We expect that this year Vellore and Bangalore, St. John's also will start their MD programs. You know, the red tape for starting new courses are so horrendous. And the curricula are ready. And someday, if one of the medical colleges in Tirunelveli will agree to work with us, this will be a great thing to do, because we find medical students probably the most receptive group. In any group, there are disillusioned students. Hey, is this what healthcare is all about? Are we really doing justice to our patients? Those are the people to reach. And teaching pain management and palliative care to medical students and nursing students is so precious. And in February 2014, this year, 22nd of February, on the last day of the Indian Parliament, the Parliament finally passed an amendment simplifying the narcotic regulations of the country. Next month in July, on 21st and 22nd, a national meeting of excise and drug controllers of the country will happen in Delhi, where the guidelines for doing this will be given out to them. So in the next 3 months are supposed to be the phase of transition. By the end of the year, if you need morphine, and if your institution has one doctor with training in palliative care, then getting morphine will be necessary. If this happened 1 year earlier, maybe that family in Kanjangad need not have suffered as they did. So all these are happening. We have concerns. We have concerns that the local officials used to going through a lot of red tape may create new hurdles. We together have to act as watchdogs and make sure that the system is implemented with its principle in mind, without bringing in additional complications, without causing new restrictions. Next please. I stop here just by saying that fortunately, as we are in Tirunelveli, training is easy to find, and in Trivandrum we are doing 6 weeks course in palliative medicine and palliative nursing for doctors and nurses. And just for the license to prescribe morphine, though whole of palliative care will not be covered at that time, the fundamentals of pain management for doctors can be learned with a 10-day foundation course. So these are available. Now, as I said earlier, the majority of palliative care is to be done by non-medical and non-nursing people. The social, psychological and spiritual aspects of it. But without that critical initial thing of the medical input, it's very difficult to give any psychosocial spiritual support when someone is screaming in pain or unable to breathe. So these are the requirements. Sorry that I took up so much of your time. I'll stop there. If there are any questions at all, I'll be happy to answer them. Thank you very much for the patient listening, and Shankar Mahadevan and colleagues, hearty congratulations to you on your great achievement. I want you to know how much I have respect for this group assembled here. All the best to you.
Control of pain in a common man's language.
Control of pain as well as other physical symptoms like breathlessness, a bad ulcer, a pressure sore, inability to move, etc. And also psychological, social and spiritual support.
Cannot be cured, but at least he will be peaceful.
That's exactly it. Improving that man's quality of life. Making life livable for them, instead of the man living a living death.
Do we have enough R&D, research and development for this palliative center in India?
No. Palliative care still is in its infancy in the country. 80% of the palliative care centers available in the country are in Kerala. There are 146 centers which stock and dispense morphine with doctors and nurses trained in palliative care. The rest of the country all put together has very little. With all the budget allocation so far has been practically on the non-governmental charitable sector like ours, with only a little bit coming out in Kerala from NRHM, and a beginning has been made in Tamil Nadu, though it is still taxiing, it has not taken off. So leave alone research and development. This is a toddler learning to walk. Research in palliative care is practically non-existent in India. Though we have put it as one of our objectives, we are not getting there yet. At the government level, as I told you, it's only a year and a back that after 20 years of efforts, they finally accepted it as a part of healthcare. And things change slowly in our country. But I am so glad that somebody is thinking in terms of R&D, because many of us, confronted with all the patients, are not even thinking enough in terms of the future. We are struggling with taking care of the things today. We have very little time to think of tomorrow, and we really are struggling with that. The very question means that you will be able to help in that aspect. Thank you.
It's an extraordinary presentation, Doctor. Really, you said that you have taken a little extra time, but then we feel as though that we should go on for another maybe 2 hours.
Very kind of you. Very kind of you to say that, sir. Thank you very much. For we do in Trivandrum, we do do a training program for doctors and nurses. But while we do the 6 weeks course for doctors and nurses 4 times a day, because we do not have enough people, we do this only once a year. Again, we have problems, especially with social workers. We can do a program only in English in Trivandrum. So people come especially from North India, and we speak English with a, as you can hear, with a very thick Mallu accent. So sometimes people find it harder to understand. So we welcome people who can speak English and handle that for social workers training. Another thing that we want to develop is a proper counseling course. We have not developed that either. I'll be happy to give you my card, because if you're interested in that social workers training, we'll discuss that. Questions? By our organization and maybe Shandil's organization, the services that we give are entirely free. There is a question asked: if there is a rich man coming in, why should we give it the treatment free? He should be made to pay. The simple fact is, all the rich people are going to the 5-star hospitals and suffering. 82% of our patients are poor. Only 18% of the patients belong to middle class or well-off families. It's difficult for us to create a system for billing and collection. That itself will be difficult. So what we tell people is, our services are free. We are expecting that those who can afford to should give donations. Many people do. Many people don't. But the most heartwarming thing is, our biggest source of income is forever from families of patients whom we treated and who died. Very often the families keep sending money. Often at the man's death anniversary, instead of giving gold coverings over flag mass in temples, or having gold crosses in churches, this is the way they worship God, by giving something to help others. But you have brought out a point. We have to give the services free, because by the time they reach us, the middle class man has become BPL. So if I write out a prescription, it's of no use. They cannot buy it. So we have to give the service free. There's a limit to the funds that we can generate. So funding is limiting our progress very clearly. Thank you.